我们到下一位讲者是来自巴西的 Dr. Felipe Faccini。他是一位巴西血管学家和血管外科医生，也是巴西血管外科医生学会正式成员，他也是全球7法专家组的成员。他今天要讲的题目是血流动力学硬化疗法，以及如何将血流动力学和引静脉保留技术普及到所有外科医生。Okay, yeah. So our next speaker is Dr. Felipe Faccini. He's an angiologist and a vascular surgeon practicing in Brazil. The topic he's going to share with us today is about the hemodynamic sclerotherapy and how can we diffuse hemodynamic and saphenous preservation to all surgeons.
First, I'd like to thank the committee of this meeting for the kind invitation. And I'm here to present hemodynamic sclerotherapy and how can we diffuse hemodynamic concepts and saphenous preservation to all surgeons. I'm Felipe Faccini from Brazil, member of the Global Chief Advisory Panel and titular member of the Brazilian Society of Vascular Surgery, director of the Clinic ProSafena in Brazil, and author and editor of a book about saphenous preservation. The first thing I like to discuss here is why is it difficult to diffuse hemodynamics? The first thing we need to know is that it's easier to market and to charge for equipment than for knowledge. I've seen this in Brazil, and people can charge more, and it's easier for people to sell an operation with an equipment than an operation that is based on the knowledge of the doctor. Another reason is that surgeons want easy stuff. The world is going this way, and there's no point in fighting that. I think we should adapt to diffuse in this world in which surgeons and people want easy stuff. Another thing is that today patients spend a lot of time in social media, like TikTok and Facebook, Instagram, and they receive a lot of wrong and misleading information in this time they spend in social media. And later, when they need to choose a procedure, they choose the procedure based on the things they have seen in social media. And most of the things are misleading and are wrong. And that's what we need to fight. What about surgeons want the easy stuff? The world is going away that people have not the patience to wait for things. They don't want to read the whole book before starting doing a procedure. They want something easy, like they can watch in a video and they can perform. This is terrible, but it's the truth. It's the world we live in. And I came in Brazil from many strippings and endovenous laser ablations. I have more than 1,000 of these procedures before I started preserving the saphenous vein. I was, like people say, a saphenous serial killer, as most people here in Brazil. And it's not easy to go from a destructive background to preserve the saphenous vein in all cases. That's why in the book I edited with Professor Claude Franceschi and Professor Stefano Ermini, I put this experience and I divided the procedures in the easy procedures and in the hard procedures. The easy, you don't need too much knowledge to do, and the hard procedures should be done by surgeons with a good experience in the topic. One thing that is important to consider is that young surgeons in Brazil, and I think in most places worldwide, they are doing only endovascular procedures. They are not used to dissect a junction and to dissect the saphenous vein and femoral vein as older surgeons were used to do and are used to do yet. And that's why I suggested in the book that procedures involving a lot of hemodynamic knowledge and a lot of ability to dissect the femoral and the popliteal junctions should be done by surgeons with more experience. Another thing I think we need to change in our way to diffuse the knowledge of preserving the saphenous vein, we need to know what the others are doing. What I see in the social media today is that old adage that say, a lie told 1,000 times becomes true. Surgeons use the word treat the saphenous vein instead of burn or destroy or eliminate. A lot of patients think that the saphenous vein will be working after ablation. That's what I see in Brazil. People are selling burning the saphenous vein as like recovering or treating the saphenous vein. This is terrible. This is a lie, and I think we should stress that and get people to know this. Another thing that I see that is a point other procedures are doing in their marketing is that surgeons market the idea that cutting the skin is worse than destroying 1 million veins by puncture. And we know that this is not true, but they sell the procedures like there's no cut, it's not an operation because it's only by puncture. They sell it's like a minimal procedure, and we know that an endo laser ablation, you can have deep vein thrombosis, you can burn nerves, you can have a lot of complications that are not included in the idea that is sold for the patient. I know it's sad, I know it's wrong, but I think we should act on it. Another thing that surgeons usually mislead patients is that the idea that the deep system compensates everything and is perfect is far from a correct idea. How is the blood from the skin and from the areas going to the deep system after you take the saphenous vein off? The blood will need to create a lot of collaterals that will need to find another saphenous vein or a perforator to get to the deep system and finally go to the heart. So I think we should express these things, and we should tell people and show people, maybe actually using social media as the others are using, to show the truth. I think we should spread the word in a positive way, just clarifying people. Criticism makes people close to the idea. So I think we should show the positive things of the procedures preserving the saphenous vein to general public. And maybe a marketing action coordinated by our group, showing the same reality with marketing ideas and art material and text in different languages. Maybe it's a good idea to show this to general people, and maybe that's a way to avoid this overtreatment of saphenous veins that is happening nowadays. Now I'd like to show you the mini Shiva procedure. That's something we did actually to fight that idea that any operation with a cut is a problem, and to make the Shiva cuts smaller, we use a duplex to check where is the collateral that we need to ligate, and then we pass with a needle and a line, a thread, we pass behind this collateral and we pull it close to the skin. And when we get this wire thread, what do we do? When we get this line, the vein is really close to the skin. Then we can make a small cut, in my experience, half the size of the large cut. And this makes less surgical trauma and makes a more static result of Shiva procedures. I think it's a good way to fight the idea that cuts are terrible, keeping the hemodynamic advances that we've done and we've made in the last decades. Now let's talk about hemodynamic sclerotherapy. That's another procedure that made me able to preserve a lot of saphenous veins, and as there is no cut, it's maybe preferable to most procedures people are doing, destroying the saphenous vein. It's easy and has good results. The first thing I need to stress here is that we need to understand the disease to treat it. The difference between a well-practiced sclerotherapy and a sclerotherapy made in a static clinic is venous hemodynamics. That's the only difference. If you don't know what you're doing, you are just injecting. You are not more than someone that is doing statics without medical knowledge. I think knowledge will take us to the future in venous disease. We need to discuss something about ascending reflux. The reservoir degenerates and creates venturi aspiration, and this aspiration creates turbulence that further degenerate the veins. That is the main principle of the ascending reflux. This has been proved. Van Riege, Govin, and Vincent published some papers showing that the microvalve degeneration is really associated with chronic venous disease. So that idea that the reflux starts only at the junction is not true. This is something we know nowadays. The descending reflux theory tells that the hydrostatic pressure created by the column, the height of the column of blood, makes a pressure in the valves, degenerates the valves, and these degenerated valves start degenerating further valves distal to the reflux as the column starts to grow. So the column degenerates one valve, and then the column is bigger, and then will degenerate another, and that's another theory of reflux. This is particularly important for Shiva because we know that femoral to saphenous or pelvic leak to saphenous or perforated to saphenous, and and all of these go into a collateral. This is what makes the transmural pressure increase, and this is what creates the degeneration. One thing we need to discuss also is that reflux is not a disease. We should be careful not to criminalize the reflux. And the reflux may be physiological, okay? How can we say that? For example, the PERTS test, we simply put a rubber band in the leg of the patient and tell the patient to walk. We know that most veins diminish in size, and the sixth saphenous vein idea is in most cases more fake news than a scientific reality. Another thing that people need to be aware is that the saphenous reflux may revert to upward flow when you treat the collateral that is creating this reflux. If the reflux is directed to the deep system and the superficial reflux is abolished, we see symptoms improvement even without the reflux reversion. So, for example, I have two cases in this picture here. The first case is a collateral in the thigh that goes to the saphenous vein and goes out of the saphenous vein in the leg, this reflux, and creates a lot of symptoms and a lot of collaterals and static problems to the patients. What did I do? I did sclerotherapy of the collaterals. The reflux in the saphenous vein was reverted, and the saphenous vein started with upward flow in diastole. So reflux can be reverted. The other case is a case with a big collateral in the lateral thigh that's going to the saphenous vein near the knee. And also after doing sclerotherapy and solving this collateral, the saphenous vein stopped reflux. And so this is important, and this I think we need to show people. Another thing is that burning the saphenous vein will not create any problem. And the saphenous vein is not important because the deep system is solving everything. We should ask people, how is the blood going to the deep system? The blood is going through veins in the superficial system and creates a lot of collaterals and may create a lot of problems. This is, we all know that. I don't know why people would tell otherwise. One paper published by Engelhorn, a Brazilian guy, he made a duplex in patients, and he showed that CAP, C1 asymptomatic women have reflux in a portion of the saphenous vein in at least 50% of cases. So she doesn't have pain, she's doing the examination only for telangiectasia, and she has a sick saphenous vein. That, in my opinion, is not sick, it's only there. And duplex by telangiectasia is every time more common. So this problem is, every day this problem is bigger. This has created a lot of ablations, and this is the responsible of the saphenous genocide that is happening today. And in my opinion, this will bring in the future recurrences, ugly superficial veins, lack of graft for bypass, and lack of graft for compensation or trauma and thrombosis. So is reflux a disease? Not necessarily. About hemodynamic sclerotherapy, what vein should I treat? Does the theory ascending or descending matters? The theory of ascending or descending doesn't matter. It's what do we do? The collateral sending flow to the saphenous vein, we treat it with sclerotherapy. The collateral getting flow from the saphenous vein, we also treat it with sclerotherapy. We start higher at the tight and then go down to the leg. And in veins bigger than 0.3 centimeter, we use compression to improve statistical results. We find the escape point, the pathway, and the reentry. And here we need to remember that reflux is where we find it, not where we look for it. We avoid sclerotherapy flow from going to the saphenous vein using finger compression of the entrance of the collateral in the saphenous vein. It works very well in small saphenous veins, but we should remember that even in cases where we cannot revert the reflux, the patient with less superficial veins may have improvement in the symptoms and in the aesthetics. And how do we do in Brazil? In Brazil, we use laser plus dextrose in these patients. Some surgeons use dextrose alone. We use also foam and liquid sclerotherapy. And the deeper veins, we do the puncture echo-guided, and superficial veins, we use normal puncture for this vein. Just to show some schemes here. For example, shunt 2A, just do the sclerotherapy in the collateral. Shunt 2B, just treat the collateral. Here you will probably have a reversion of the reflux in most cases, except if is there a perforator close to this reflux. Shunt 2C, you treat the collateral with sclerotherapy, and you probably have remission of symptoms and improvement of the patient, but the reflux of the saphenous vein is probably going to be kept, and the blood is going back through that perforator. Patients with no escape points and only superficial veins, you treat that, and sometimes you can diminish the column of blood and even stop saphenous reflux that is dependent on this collateral. Pelvic leaks, you treat the pelvic leaks. In large pelvic leaks with a lot of flow, sometimes you need to do an operation because the injection will not work. But in small pelvic leaks and in that collaterals that form in the region of pelvic leaks but do not come from the abdomen, the sclerotherapy works very well. And you do sclerotherapy above and below the collateral that has reflux in the saphenous vein. Shunt 6 is another important case because we have the perforators but the principle is the same as pelvic leaks. A perforator with small reflux will probably be solved by sclerotherapy. A big, enormous perforator with a lot of reflux will probably not work the sclerotherapy treatment. We prefer operation, but in small perforators, it works very well. And we inject these perforators and the collateral to treat it. Thank you very much for your attention.
In your lecture, you are not are not only mentioned about the medical problem, but you also mentioned some problem in the information spreading and some economic constraints about Shiva's promotion. Thank you. And do we have some question?
Yeah.
Please.
我想请教这位巴西的血管外科专家，然后在向这个曲张的前表的这个静脉里面注射硬化剂，它血管都是相通的嘛？你是如何阻止这个血液向主干上去，就是如何阻止这个硬化剂跑到那个大隐静脉主干里面去的呢？谢谢。
Professor Faccini, there's a question from the floor. It's about when you are performing the sclerotherapy for the tributaries, how you avoid the sclerosing getting into the saphenous trunk.
What do? It's actually very simple. I prefer non-powerful sclerosants, and I close the entrance of the saphenous vein. I close the connection of the saphenous vein with the collateral with finger compression for 2 to 3 minutes. So I do the duplex, I check where this collateral is going to the saphenous vein, and then I close this point and inject in the rest of the vein. That's what I do.
Thank you. 我想他的意思是他用普墨the sclerotherapy， 他会用超声波去找到那个交界的地方，他用手指去压那个交界2至3分钟，再来防止那个风进入那个大隐静脉。
我是张强医生好，我是来自江苏南通如皋小县城里的一个医生。其实我在认识张强医生，我可以分享一下自己做这个保留血管的一点经验吗？这或者心得吗？谢谢。真的认识张医生是个既让人兴奋又是让人痛苦的事情。2010年我跟张医生还有一张合影，然后17年的时候张强医生集团就开始做这个。我什么时候开始做的？我到现在我叫期望是说我不敢亵渎的禁语，因为我跟我的病人说的时候，我都是说我是做保留血管的，我不敢说我是做期望的，因为确实没有得到过认证过。首先感谢张强医生集团，张强医生他建立的这个张强静脉科技这个平台，以及在那个叫掌声课堂那个里面，他那个里面有64个视频，我全部看过。我在19年的时候，在进修的时候，因为进修的时候有大把的时间，我把那个64个视频反复的都看过。之后，2020年，我也就在他们的3年之后，我就开始自己做保留血管的手术。然后昨天还在跟朱医生吹牛最近好像感觉开挂了一样。然后基本上在来拆线的时候，就已经效果都非常的好，真的。然后昨天也请教了朱医生好多问题。为什么说认识张医生会痛苦呢？因为我开的第3例人印象非常深。24岁的姑娘，还没有结婚，然后腿上有曲张的静脉，就是当你知道有一种更牛逼的方法摆在你的面前，而你还在给她去做剥脱的时候，我就觉得那是种痛苦，对一个有良知的医生来讲，真的是一种很痛苦的折磨。所以说，在那个女孩的身上，我花了相当大的一段时间，然后鼓足了巨大的勇气，因为可以说你完全没有一个，你不知道自己到现在为止。我从来都不宣传自己，为什么？因为我到现在都不知道我做的，没有一个人会告诉我这么做到底是对，我这样扎到底是对还是不对因为没有在我的身边没有像朱医生这样一个很好的导师去告诉我，所以完全是自己去摸索着去做的。然后那个姑娘呢，效果非常好，她带着半年之后，她带着她的父亲来找我，然后她刚好已经怀孕了，然后腿上那个效果是非常的好。然后在最近，我昨天晚上特意在宾馆里面把我最近做的病例全部给他对比了一下，然后总共有从8月份到10月份嘛，18个，效果真的都非常的好。所以我想鼓励一下在座的各位，我来自一个小县城的医生，我都可以做得到我相信在座的各位都可以做得到。
谢谢，感谢了，掌声给他鼓励一下。The doctor is from local hospital in China. He's totally agree that the theory of Chiva. So he did a lot of cases and achieved very successful results. So thank you, Dr. Faccini. We'll move to the next speaker. Thank you again.
你好，我有2个问题想要请教一下。
因为时间问题啊，我们把下一个结束以后，你这个问题继续来，好吧？
好，
留到下一个。